All right, so we got to kind of dust off, some cobwebs and whatnot. We haven't had a webinar since mid-December, and we're starting the new year. Our very Leslie Zuniga-Rivas, who's going to lead today's webinar. Leslie, this is we talked about. This is Leslie's third time doing it, and we're really excited for her. Third time. The other two went well, but third time's a charm. So we're looking for the charming Leslie to lead us today. I just want to highlight one thing we have just for we're at NMQF. Leslie's title at NMQF has the word equity in it, and so we're keeping with that and sticking with that, and that's always going to be a priority of ours, just in case you had any questions about that. But before she leads this panel, I just want to make two quick announcements. One, we have our National Annual Summit on Health Disparities. It's the last Monday and Tuesday of April every year. So it's April 28th and 29th at the Conrad Hotel in Washington, D.C. And so at least 600 folks come in and learn and talk about health policy and meet and greet network and all of that stuff, all that good stuff. And then we have a competition. We highlight the top 40 under 40 minority leaders in health. And there's an application for that. So if you know anyone that's interested that would like to apply or you like to recommend, we'll put a link in the chat and you can have them apply. But that's all I have. And I'm going to turn it over to much smarter people. So Leslie, I'll let you do your thing.
Perfect. Thank you so much. As Brendan mentioned, I am Leslie Zuniga. I am the Quality Improvement and Equity Project Manager for the Center for Sustainable Healthcare, Quality and Equity here at NMQF. Thank you so much for joining us today, and I'll just give a quick reminder about our Q&A function. So please feel free to drop any questions that you have. We'll do our best to answer those throughout our session today, and we will also have a few minutes left towards the end of our call to answer any questions. So I don't think there's a better time to have this conversation for our shingles awareness and sharing our successful efforts to increase the vaccine rates within minoritized communities. Next month is actually Shingles Awareness Week, so I think great timing to be able to have this conversation. So today we will be discussing how we are successfully promoting shingles vaccinations in minoritized communities. On our panel today, we have Dr. Yabo Basolo. Dr. Yabo is a public health professional. She is the Director of Health Ministry for the AMH Zion Church. She is a pediatrician, a former CDC employee. We also have Dr. Rachel Nelson. Dr. Rachel is a pharmacist at the R-Care Pharmacy in Arkansas. We also have Amy Harris. Amy is the Deputy Executive Director for NYC Health and Hospitals in Elmhurst. And last but not least, we have Michelle Lamb. Ms. Lamb is the administrator for NYC Health and Hospitals at Elmhurst. And as Brandon mentioned, we are sticking with health equity. That is the core to NMQF. So I think what better way to get this conversation started than with a question about health equity. So I'll go ahead and get started with Dr. Yabo. Dr. Yabo, how do you think equity impacts access to shingles vaccinations?
Thank you so much, Leslie, for this opportunity to share our thoughts. And yes, equity really factors into shingles vaccine uptake amongst adults across the U.S. When we look at the national level vaccine coverage numbers, we see in general for all adult vaccines that 3 out of 4 adults in the U.S. are missing one or more of those critically recommended vaccines. That's flu, pneumococcal, shingles, or that tetanus whooping cough vaccine. But when we look closer, we see that there are disparities in coverage based on several factors, including whether someone has insurance coverage or not, and also by race, ethnicity. So we're going to quickly just look at disparities by insurance coverage, just so you can see what that looks like. And you can see that for those adults who have no health insurance, in the gray bars there, less coverage versus those who have public or private health insurance in the teal. And that disparity is really pronounced for vaccines like zoster or shingles. You'll hear me use that term interchangeably. Zoster is also shingles. So for the zoster vaccine and also for the pneumococcal vaccine. So we wanted to just kind of, set that stage for our discussion today. Thank you, Leslie.
Thank you so much, Dr. Yabo. And Dr. Nelson, what role does equity play in offering shingles vaccines at your pharmacy?
Our care's mission is health for all. So right now we're just targeting those opportunities with our patients, anybody that's like 50 and over. And most of them, the conversation will get brought up when they come in and we talk about flu shots. We bring up opportunities for the shingles as well as the new pneumonia.
Great, thank you. Thank you so much for sharing that. Because I think it's always so important to not, whenever you see anybody coming into the clinic, not just share, what they're coming in for, but also what they need to know to, keep an eye out on their health. And Amy, how does your health system address equity in shingles vaccination?
Hi there, good morning. Well, good afternoon now. But we have a lot of data that we use for our program. We're lucky we're part of the largest public health system in the country. And Michelle is going to take you through some of the data that we are able to collect through our large system here that we can then stratify to look at equity and gaps in our populations that we serve.
Perfect. Thank you so much.
So, just a quick thing Amy mentioned, we are able to gather a lot of our patient information through our registration process when we collect the patient's demographics, race, ethnicity, even their pair mix and such. When we register the patient, we're able to pull that out of our EMR system, and we're able to stratify it by the various equities to see where we may be lacking equity when we are talking about the shingles vaccines. And, and as Dr. Yabo mentioned about pair mix, where non-insured patients have or may not know of or can't afford the vaccine. So we're able to break everything down by the different levels, and we're able to slice it and see which domain we're able to help increase or outreach to those patients or speak to them about the vaccines.
Wonderful. Yes, I think it's so important to be able to know what your baseline is, to be able to pinpoint if there's any specific areas that we need to, tailor any programs to, any efforts to education or messaging. I think those are also great to be able to see. But thank you so much for sharing your insights. I think you all have, very different roles in this space, and I can't wait to share a little bit more about the work that you're all doing. And something that I will share as part of the shingles work here at SHC. So we conducted a survey through our health systems that we're partnered with, some of our pharmacy partners. So we do have a CPA program, so the Community Pharmacist Ambassador Program. So we were able to survey some of our members, and I think some of their responses are definitely echoing some of the points that you have already shared. So we learned that not all clinics actually offer shingles vaccines, which I think I was a little bit surprised to hear that. We also, gathered some insights on why some patients might not be getting their vaccine. Some of that was noted to be concerns for side effects, eligibility status, cost being a big concern. That I think that was one of the biggest ones that was flagged for us. The patient might thinks that they are not at risk. They're not aware about the vaccine or even what shingles might be. The clinical staff might not have the correct messaging. That was also a big thing that was flagged for us as well. We also asked what they think would be the biggest difference, to be able to increase the vaccine rates within their patient population. Some of those mentions were education, community events, having the proper messaging tools, reducing the cost for the vaccine or completely cutting the cost. I think that would be a big thing that would definitely alleviate that pressure to be able to get the vaccine. So, obviously barriers are at the core of disparities. So that'll be something that we'll be jumping into a little bit more and further discussing throughout our conversation. And as we start this discussion, I do want to acknowledge that we do have a very diverse audience. We have everybody from clinical partners to our wonderful community partners on our call. So I do want to give Dr. Yabo this space to be able to share a little bit more background information on what shingles is, the disparities that we're seeing in this space, and also the vaccine guidelines.
Great, Leslie. So yes, so you'll hear me again use terms interchangeably. Shingles referring to zoster, and then varicella referring to chickenpox. But shingles is unfortunately common, especially in our older adults. In fact, your risk for shingles increases with age. About 1 in 3 individuals will develop shingles in their lifetime. And what causes it? It's really the same virus that causes chickenpox. When you contract chickenpox or contract the virus, that virus lays dormant, silent in your body and can reactivate decades later. So whether you remember having had chickenpox or not, you're still at risk of developing shingles. It's a very painful, usually itchy rash, and you will see me share this on the screen shortly, but really it's a rash that forms in what we call the skin dermatomes, or that layer of your skin along it like a stripe. And it can present as being very itchy in that area before the rash appears, painful. And we also wanted to share that the rash can look different on different skin types. So you will see in Caucasian skin where the rash may be more blotchy and red. In African-American skin, it can show up as more pustules or more crusted looking, and it changes over the course of the illness. Some people may experience signs and symptoms like headache or trouble seeing bright lights or being very fatigued when they come down with shingles. But these are not the only manifestations of shingles. It can also be pretty serious. You can have hearing or vision loss as complications, and then something called post-herpetic neuralgia. That means persistent nerve pain in the area where the rash was. And we see this a lot, and there's even a testimony that we pulled from the CDC site, someone mentioning a 63-year-old harpist who was unable to continue playing because of shingles. They are saying 5 years later, they're still taking prescription medicine for pain. Their rash initially developed into open, oozing sores that in only a few days required them to be hospitalized, could not eat, sleep, or perform even the most minor tasks, totally debilitating, still limits activity levels to this day. So this is not a benign disease. And we know that we have a lot of work to do in preventing it with the shingles vaccine. But as Leslie said, we're still seeing some disparities by race and ethnicity with regards to vaccine uptake. And this is a pictorial here of results from a 2023 publication by CDC, which shows shingles vaccine uptake by age 60. And for those over 19 years of age, and you see that the disparity is pretty wide there, with white people having coverage rates of 55%, but Black and Hispanic individuals only have 40%. So definitely some disparities there. Leslie, you asked me about recommendations for the vaccine. So just really quickly, we wanted to share with everyone that there are vaccines for adults. So we wanted to say this first before we even move into shingles vaccine, because we want you to share this. This is an easier to read schedule. You can share in your communities, in your practices, so that all adults are aware that there is even a vaccine schedule for adults, with one of them being shingles vaccine. This vaccine is recommended in 2 doses. It's about 6 months apart for everyone 50 years and older. There's no maximum age. So once you're 50, you're recommended to get this vaccine. If you're immunocompromised, then you can start getting it at age 19. Even if you've had shingles before, because you can get shingles multiple times, it's recommended that you get the vaccine. Of course, now when you're actually ill with shingles, you have to wait till the rash is all gone. Even if you've had chickenpox in the past or you don't remember, you're still recommended to get the vaccine. And for those adults who may have received that older vaccine, which was the live vaccine years ago, they should be revaccinated with this 2-dose series of this new Shingles vaccine, newer, I should say. So those are the recommendations there, Les, and I'll turn back over to you. Thank you.
Thank you so much for sharing that information with us. And I want to start opening the discussion to our other panelists here. So I know we've already discussed a little bit about the barriers that we're seeing in this space. But Dr. Nelson, I'm curious just to see, what you're seeing on your end as a pharmacist, and especially in your pharmacy, any specific barriers that you're seeing. I know, insurance is a big one that we've noted. So anything that you would like to share about that?
Yes, thank you. We pulled some data and we looked. A few patients did have maybe like a high copay on their initial single or first dose. Did notice that they did not return for their second dose, and so I'm not sure if it's because they had to pay for the first one. Another one noticed that the patient sometimes they don't remember if they've had one. Now with the going from the Zostavax to the Shingrix now, again, we're just making that recommendation that if they don't remember, to go ahead and start the series of the Shingrix. And then another barrier was just the education, just the not knowing, if they had chicken pox, or they were confused that they've had chicken pox and didn't understand why they would need a shingles vaccine. Another barrier that I wrote down was side effects. We've had quite a few people just say that, it caused a lot of tenderness, a lot of swelling in their arm. And again, that could push where the patient may not return for that second dose, or they've talked about it enough around friends, family members, that they were discouraged to get it. I did note that there was also risk for like Guillain-Barré that was brought up, and just knowing someone that has been through that. The only other thing I noted that I did have was a misconception. I had a patient that was around someone that had shingles, and she thought that she could catch shingles, and so then she asked about being vaccinated against shingles. She was not of age to actually receive the vaccine, so we just had that conversation and just talked about talking to her PCP and possibly returning at a later date. So
thank you for sharing that. Yes, I think going back to the education piece, and then misconceptions. Is there any other common misconceptions or myths that you're hearing surrounding the vaccine?
Again, it was just more of just the side effect, the injection site, the redness and the swelling. I didn't notice anything other than that.
Okay, thank you so much for sharing that. And Amy and Michelle, I know you both work at a very, very large and diverse hospital system in New York. Can you provide a little bit more background information on the population and the community of your health system?
Of course. So Elmhurst Hospital is actually located in Queens, New York. And according to the US Census in 2020, there were 3 most diverse areas in the United States. Anchorage, Alaska was one of them, and Queens County was the second most diverse community. And out of Queens County, we are actually located in Elmhurst or Jackson Heights. And I can say in our zip code, our 11373 zip code, there are over 94,000 people that live in that one zip code, which is part of our community, making Elmhurst the 8th most populated zip code in New York State. Our population is mainly made up of predominantly Hispanics, Latinx, followed by Asian Americans, and then Black African Americans. Over near 60% of our patient population is of Hispanic descent. And then the 20% or so are Asian Americans, followed by Black African Americans and white. So a lot of our patients are first generation immigrants. We are very close to LaGuardia Airport. So when they do come, they settle in around our area. English is not their first language. Over 54% of our patients have a preferred language that's other than English. So we do have to be creative, ensuring that we provide, communication to our patients in the proper language, especially when it comes to vaccine and their healthcare and such. We want to make sure that they're understanding what we are offering, what some vaccines are that we're giving them, what are, how we're treating them for their healthcare. The unfortunate thing about having a lot of first-generation immigrants is we do have patients with high social determinants of health needs. A lot of our patients are experiencing difficulty with medical costs or health insurance because they are either underinsured or just uninsured. As Dr. Yabo mentioned, that's one of the barriers for getting the shingles vaccines. We also have patients who, they have a lot of educational needs. They come over to the US with elementary school education, so they don't understand the importance of vaccines and how they help keep us healthy. So
Absolutely. So thank you for sharing so much about your health system. And I know you already mentioned, a few of the challenges that you face, or, certain barriers. Are there any other barriers that you're facing, for shingles vaccination, not just with your community patient population, but also within your clinic? I think it's also always important to note that some of the barriers can come, within the clinic.
Yes, I think that originally when we started the look at shingles vaccination, we weren't even sure if our pharmacy had the shingles vaccine on formulary. So we had to go and ask. We're like, do we have shingles vaccine here? Do we have Shingrix? And that was a question. I mean, we didn't know. And if we didn't know, we thought, well, surely then some of the providers and nurses may not know. And that was true. They did not know. So, right away we knew we would have to do, by the way, we did have it. We had it, but we only recently got it. So I'm like, well, did I miss the announcement? And they're like, well, it was kind of, the people that are on the formulary committee were told about it and they were supposed to tell others. So communication was not our strong point at that time. So we're like, oh, well, we have to, work to get this, information out. So we had to educate internally to our providers, our clinical care team members, to make sure that they were aware. So we started a performance improvement team. And one of our first initiatives was to just kind of do communication blasts about that. And then, as we went along, we did a number of things, including creating the thing that really helped us the most here was creating a shingles vaccine as a non-patient specific standing order, the NPSO, which really, that was a game changer for us. That just made it part of, many of our other standing orders, so that our nurses and our clinical care team members could just get that vaccine out to our eligible members right away and make it part of just what we do as a primary care practice.
Thank you for sharing that. And I think, again, the messaging, I think, applies also not just to, as you mentioned, within the clinic. I know Dr. Nelson also mentioned anytime a patient comes in, providing that message of the shingles vaccine. And something that I always like to remind people of is, even if, whatever disease area that we're, talking about, or vaccines, anything like that, you always know somebody that would fit into that age group. So even sharing that, just because that person might not look like somebody that needs the vaccine, that is still a message that they can carry back to a loved one, or somebody else to be able to share that information with. And thank you all for sharing your expertise and insights. And I think, just to highlight again, you all play such varying roles in this space. I do want to also note that At NMQF, we obviously like to bring attention to the problem, but we're also action driven. And I want to share some of the great work that you are all doing in this space, solutions that you have found. Our center is known for our quality improvement work. So we have our DRIVE toolkit, and that is the framework for how we create equitable quality improvement activities with our clinical partners that are on our call today. And Dr. Nelson, your pharmacy has actively participated in our QI programs. Amy Michelle, your health system Elmhurst has been one of our leading partners in this work. And you've really helped us demonstrate how impactful community-driven quality improvement can be. And our DRIVE toolkit. So our toolkit is really a guide for clinical teams to be able to connect with their communities, identify barriers, and be able to really tailor sustainable activities to improve health outcomes. In this case, increasing shingles vaccination rates. And Dr. Yabo, who is one of our panelists on this call today, your expertise has guided the your expertise has really shaped our DRIVE toolkit. So ensuring that it's a robust resource for those working to make a difference. We will be sharing that resource here in our chat for you guys to be able to access. Another resource that we have is our Community Pharmacist Ambassador program. So the program collects, we create modules to be able to really equip pharmacists with the needing messaging and guidance to improve health within their communities. So we'll be able to share those resources in the chat with you. And again, those are all free to access. And we would love to hear how you share those within your communities and with your colleagues. So I will start guiding our conversation a little bit more to the activities that you guys are all doing, within your health systems, within your pharmacies. Can you, Dr. Nelson, share a little bit more about your quality improvement work that you've done as part of a program with us, and what you found to be most successful?
Our care utilized the marketing team. We have a sign out at the road. We're located actually in a grocery store, and so we have signage out by the main area of traffic to let people know about our offering of the shots. We've done t-shirts, little pamphlets, word of mouth. We do have a clinic. The clinic is not attached to our pharmacy, but just promotion again through just our marketing team.
Absolutely. Thank you. Yes, I think awareness and education are definitely some of the biggest things that we can do in the vaccine space, especially. How has all of these efforts and messaging and all of that, how has that been received by your staff and patients?
It's gone well, and it promotes conversation.
Perfect. Yes, we love to see that. And again, just because that person might not fit, the age group that we're looking for, they can still carry that message out to anybody else that might fit that a little bit more. And Amy and Michelle, can you share a little bit more about your quality improvement work that you were able to tailor for your community and population?
So what we did for our community is during the winter, it just so happened that, during the winter months, we always go out to our community to offer flu vaccines. So all the members of our community who can't make it to the hospital, but as we were promoting the flu vaccine or offering the flu vaccine, we're also giving out the flyers and educating the community on the shingles vaccines. So letting them know, aside from age, there may be other qualifiers that can qualify them for the shingles vaccines, and we urge them to speak to their primary care provider. And of course, we also promote if you didn't have a primary care provider, we can always offer one for you. So it's like a twofold, growing our patient population and spreading information to the community on shingles.
Thank you for sharing that. Any lessons learned or new practices for that you gained throughout the program?
Oh, Amy, do you want to speak to that one?
Yeah, I think again it goes back to it's PDSA, Plan, Do, Study, Act, right? And so when we look at our data and we pull our data and we look at all our groups, we were able to look at our data by clinics that we have. And so we were focusing on our adult primary care clinics, and we have a very large adult primary care practice and a very large adult geriatric practice. But we also, and we were very hyper-focused on them and getting all that communication out to them and those providers of service and the clinical staff there. But we have a much smaller population of primary care patients in our immunology clinic. And we didn't do a lot of education or focus there, and their shingles vaccination rate is lagging. So in a way, all the work we did kind of ended up being its own PI with, you know, if you do this here, you'll see the rates improve, and not doing it here demonstrated that not doing it will keep you from not improving, even though it was in the formulary. Just having it in your formulary is not enough. Having it as a standing order isn't just enough. You have to make people aware of what is available, both in not just to the clinical teams, but also to the patients, because you do want the patients to be educated and to ask for that vaccine. And so the combination of everyone knowing about it, plus having it in the formulary, and making it available to every payer, regardless, whether it was something that their insurance paid for or not, everyone was able to get it, makes a difference. So now in a smaller PI, an offshoot of, like, you know, a spin-off of the original PI, we have a more focused one for this smaller group, which will now allow them to jump forward and catch up to the other team with their shingles vaccination rate. So it's always so important to get your baseline data, look at your data after implementation, and then look at areas where you're still not improving, and go back and make those changes that you need to.
Yes, and that is, you know, truly the backbone to our DRIVE toolkits is really the PDSA cycles. But I always like to say that we take a little bit more of a spin on it to focus on equity, and again, being able to see what areas we need to narrow down a little bit more. And I think you've done a great job of, you know, really following the steps and being able to create these programs that are not just, you know, equitable, but they're sustainable. So we always like to think of programs that the staff is going to, you know, buy into, that it's going to be followed and it's going to be promoted. So I think, you know, what Dr. Nelson's pharmacy is doing is great, of, you know, the messaging, and also being able to, you know, continue that outreach to multiple patients. As part of this program, we've created some infographics, and I think those were posted in the chat, but we have those available in English and in Spanish. And again, the thought behind our educational material is always a conversation starter. So whether that is, you know, something that we're going to have posted up in the pharmacy or in the lobby, or t-shirts, anything like that, or it can also be a guide to, you know, really having the clinical staff be able to have a sit-down conversation and, you know, detailed, was this the right vaccine for you? Are you, you know, do you fit into this age group? Do you fit into the criteria? You know, sharing some of that information, being able to reassure patients that, you know, the recommendations are for their health. So again, those resources are should be in the chat now. And again, we always like to think of those as conversation starters and guides to be able to promote health education and awareness. And I know, you know, our QI teams here have already shared a little bit of background on their activities, but I'll hand it over to Dr. Yabo, because I know, you know, obviously awareness and education is so important, not just to our patient and community population, but also within the clinic. So I'll have Dr. Yabo share a little bit more to see how SHC's DRIVE toolkit can help address some of those disparities.
Thank you, Leslie. And You've heard how our colleagues have eloquently shared their experiences with the DRIVE toolkit, and also just a lot of the barriers that can lead to health disparities, including that lack of awareness by the patient that they're due for a vaccine, or lack of recommendation by the provider's office, what we call missed opportunities to provide recommendations, counsel the vaccine, about the vaccine to the patient, and then also other barriers, concerns from the patient, as Dr. Nelson mentioned, that the vaccine is not safe or that it's not effective. And so the DRIVE toolkit and the QI process is a way to systematically involve all parts of the healthcare delivery system. As Dr. Amy mentioned, how can we avoid those missed opportunities? How can we ensure that our staff are also knowledgeable about the disease and the vaccine that prevents it? Ensure that we're looking at the needs of the community that we're serving. We're asking them, did you know that there is a shingles vaccine? If yes, are you going to take it? If not, what are some of the reasons why? So we have all those resources in the toolkit, like a community needs assessment sample. And then finally coming together as a QI team in the healthcare setting, involving not only the front office, but also the back office, also the billing department and leadership to work on ways to improve uptake. So we walk you through these quality initiative processes, and we even have sample processes, which I'll share with you, such as the Plan, Do, Study, Act cycle that Dr. Amy mentioned. And we have a sample PDSA that is available in the toolkit as well. So those are all ways that you can use these in your setting to implement small changes over time. As Dr. Amy mentioned, check, is it working? Is it not? Do I have to pivot, try something new, or do I continue what I'm doing because it is working? So the steps there to the PDSA cycle, and then a sample PDSA, for example, that you may use in your setting to ascertain what is my baseline rate and is it improving? So that is truly the benefit of the toolkit, and we welcome you to download it and ask us questions if you have any questions about it as well.
Thank you for sharing that. And I know, as I mentioned, that resource should be in our chat. So we always love to hear the great work that everybody's doing. So if you use our toolkit, or even, create any program, we have that available for multiple disease areas. So not just for the shingles vaccine space, any disease area that you're using our toolkits. We always love to hear the success stories or any questions that you might have about that. Please do not hesitate to, reach out to us. We always love to hear about the quality improvement work that everybody's doing. So again, just to circle back a little bit more on some of the barriers and how we're overcoming these. I know we've already mentioned a little bit about cost being a big factor as to, why some people might not get the vaccine, or I know Dr. Nelson already mentioned, some would hesitate to come back for the second vaccine. Is there any other information that you can provide us, Dr. Nelson? I know Medicare coverage is available for this vaccine. So if there's any other information or background that you can provide to us for that.
I just wanted to mention, I did visit the Shingles website, and they actually have a tab to select and check your insurance plan's coverage for a vaccine. With the way our care works, a lot of times we try to find some way to maneuver and help the patient pay for their prescriptions. I could see us maybe working on something to provide to help cover cost of vaccine if their insurance isn't covering.
Thank you for sharing that. Amy and Michelle, is there any other information that you can provide about coverage surrounding this vaccine?
Yes, of course. So we've noticed that for the vaccine, there are prescription assistance programs out there. We, look at the right sites and such. So we try to assist patients in applying for those and seeing if that'll help them offset some of the costs or cover it in full.
Thank you. Any other solutions or initiatives that you are aware of? I know a lot of what you've already mentioned is actually a part of our DRIVE toolkit. So we do have, not just resources on, what shingles is, but also how to plan the QI program, and also resources for staff to be able to, look into a little bit more on how they can, cover these costs. I know Dr. Nelson already mentioned, going directly to the GSK website to, be able to input your information. So that can definitely be a big tool. But anything else program-wise that you're aware of for coverage, costs, billing? I know billing's been kind of a common topic as well that we heard throughout our survey, of just not being aware of the proper codes to utilize or anything like that, or how you've been able to kind of overcome any of those challenges. Anybody from the Elmhurst team, if you have anything else to share on that end?
I guess it all really comes down to communication and education for all staff to ensure that everybody's on the same page and we're doing the right thing for our patients.
I think we have a few questions in our chat already, so we can go ahead and address those before we get to our closeout questions. Let's see. So we have a question on our chat. So given the recent Trump executive orders on DEI, what is the go forward approach and strategy for equity work in this space? Sorry. I think what we are focusing on is still continuing our efforts in the equity space, continuing education and awareness. As Brandon mentioned, that is something that we are sticking with and pushing forward with equity overall. And I think, at this point, it's also something that we have to wait and see, what's going to change, what action we need to take. But overall, we're still continuing our efforts for education, awareness, providing resources, and anything else that our communities might need. So is there any other questions that we have from any of our attendees? I'll move forward with one of our final questions. So what is one key takeaway or actionable step that you would recommend to improve shingles vaccination rates and ensure equitable access? So I'll point the question to you, Dr. Yabo. So any, one key takeaway from our conversation today?
Sure. Just for everyone to remember that, everyone's at risk for shingles. Anyone who's ever had chickenpox, even if you don't remember having it, especially our older adults, as we age, that risk increases. People with weakened immune systems are at risk, so they need to be vaccinated earlier, starting at age 19. And just the importance of having that usual place for healthcare and routine physician contact. We find that as one, again, the barriers when someone doesn't have that healthcare home. So we strongly encourage, welcome the community to develop that healthcare space in your setting. The standards for adult immunization practice recommend that providers not only assess vaccination status at every patient visit, as our colleagues have mentioned, but that they offer needed vaccines or refer patients to other vaccination sites if vaccines are not available. And then using these evidence-based interventions, such as provider reminder systems to ping you, as Dr. Harris mentioned, that this patient is due for a vaccine, not only in the primary care, but also in those specialty clinics. And then the standing orders to improve vaccination coverage. So those are all some of the takeaways I took from the conversation today and wanted to share, and thank you.
Thank you. And then, so Dr. Nelson, so what is one key takeaway or actionable step that you recommend to improve shingles vaccination rates?
First will be promotion. I think a conversation with our clinic in town, just to see, maybe that's part of the triage, to ask the patients not only about flu shots are always a big one to be questioned, but just ask about shingles and maybe provide some education, a handout or some sort I'll get with our marketing team to see if they can provide that maybe to the clinic. I just really think that the patients tend to gravitate more to their provider and the education from them. And then again, a conversation that could lead them to come visit the pharmacy afterwards.
Yes, absolutely. And I think it's always important to have, you know, even just tips and recommendations to know how to start those conversations. Because sometimes even just asking, do you have your shingles vaccine? That, you know, we could be missing so much more that we could, you know, potentially share with that individual. So as Dr. Yabo mentioned, there's being missed opportunities to be able to share more of the vaccine. You know, their answer may not reflect, you know, if they truly have gotten the vaccine, or they just mean that they might not be aware of that. So I think, like you mentioned, taking any opportunity to be able to share that information. And Amy, what is the one key takeaway or actionable step to improve shingles vaccination rates?
I think, you know, for increasing vaccination rates, the first thing I would do is just know where you're starting from. You know, collect your data, always have your data. The data doesn't lie. I mean, you have to know where you're starting from, rely on your data so that you can communicate your data. You can show that you have improvement and that you've made effective changes. So I would say, you know, do a lot to get your baseline data to demonstrate, you know, change in performance.
Yes, thank you for sharing that. I think that is absolutely a big key takeaway for this. I think we always, you know, try to do all the big programs to have a big impact, but sometimes, you know, even if you put in all of your effort, it might not be targeted to the area that you need to direct that to. So I think, again, just being able to know your community, see what gaps you can fill, any disparities that you're seeing, to really be able to tailor all of those programs. And again, just being able to make that as, you know, as sustainable as possible, and repeating again those efforts, as we know, as we heard earlier from the Elmhurst team, you know, doing the QI program and then also repeating that evaluation and seeing what other gaps or what other areas do we need to focus on in the entire clinical system, kind of flags some stuff for you guys. So I think that's great to be able to, you know, see what lessons learned and what the continued work is going to look like. And Michelle, what is your key takeaway or actionable step for improving shingles vaccination rates?
To really keep an eye on the data. You know, seeing the baseline is great, but as you go through the various PDSAs, to go back and check to see if those PDSAs work. If it didn't work, it's okay to go back and do a second PDSA. And then once you see something that works, still continue to monitor for improvement and sustainments.
Thank you so much for bringing that up. And yes, I think it's important to also not be discouraged. It's so important throughout your PDSA cycles to be able to have that evaluation. I always like to think of it as lessons learned. It's not really a failure or anything like that to, you know, to look at. It's always what can we do to improve? What other area do we need to focus in on? So again, there are always lessons learned in this space. And I think something that I think we can always bring up a little bit more in this space, especially with the work that we do as community partnerships. So I know for our program, we've been creating these educational materials for our community partners to share, but I can, you know, I want to bring up a little bit more of some of the other work that you all have done within your communities. So I know Amy and Michelle Elmhurst has done some great work, not just sharing, you know, the resources within the clinic, but also just being present within your community. I know you always do the food drives, holiday events, anything like that. I think that's always a great opportunity that you guys take to be able to continue to share this information. Is there any other information that you can share about these efforts that you do within your community?
We continue to promote, you know, as much as we can, although not all patients are patients of ours, but we see it as, you know, as long as the community is healthy. I mean, we saw it during COVID, the pandemic, when, you know, we were, I hate to say this again, but epicenter of the epicenter. And then once the vaccine became available, we were able to see the quick turnaround on the COVID vaccine infection rates for us when our vaccine rates increased to the 90th percentile. And then we saw it over various communities within our site, where certain communities had a high infection rate. So once we started promoting and sending out, staff to help vaccinate those various communities, as they improved, less patients came into the hospital. So those hospital beds were able to be saved and reserved for people who really need it, instead of coming in for something that's preventable by a vaccine.
Yeah, so it's amazing to be able to see the trickle down effect, not just of, you start a program with your one focus, but then you also start to see these other great, efforts to start to trickle down to other areas. So I think that's always great to see. Anything else that you'd like to add on the community work that you all do?
Yeah, I'm gonna say something like what Michelle is saying. In Queens, we have very few hospital beds. So our beds we can't really, like what Michelle was saying, we can't really use them for patients who have shingles related issues, because those are things we can really prevent. And we should be preventing. This is preventive healthcare, and we should be doing this on an outpatient basis, and it should be for everyone, and keeping our patients as healthy as possible. We don't have as many beds as we used to years ago, and we see more hospitals closing and less access and capacity for, hospital beds. So it's putting more and more of a burden on outpatient facilities to keep populations healthy. And this is the one way to do it. Vaccinate your patients, make sure they're healthy, make sure they're not getting sick and coming in and getting care late, or getting things like shingles. It is painful. It does create complications that can lead to potential hospitalizations. And that, especially now when we have things like, other respiratory diseases and infections that are creating, full capacity at our hospital, that is just not something we want right now. So that is, I think, an important takeaway.
Thank you so much for sharing that. And I think that's also, I would like to think that that ties back into getting that staff buy-in, is, reducing all of that burden from, the other areas in your clinic. So I think if there's anything else that anybody else has to share, regarding the staff buy-in, I know, there's always, I know some of our previous programs have started competitions within the staff to be able to, increase vaccine rates, not just for the shingles area, but also in the flu vaccine area. So I think those are, small tips to be able to increase your staff buy-in. And obviously burnout's a big concern. So if there's anything else that anybody has to share regarding that staff buy-in.
I was just going to echo what you said, Leslie, to Dr. Harris and their team and Michelle's team. When they have those competitions, they send us our little freebie t-shirts to go along with their staff competitions, but encouraging staff members to get the flu vaccine or, COVID vaccine, et cetera. But that is also bringing awareness to the importance of vaccine, not only among staff, but in the community. And once we can get staff buy-in, that's huge. So those are great examples there. Mm-hmm.
And Dr. Nelson, is there anything, within your pharmacy or anything that you are aware of from colleagues or anything like that that you can think of that has helped with the staff buy-in?
They love swag, so anything that has our care and then promotion of the shots. I like the idea of the having a challenge. We don't technically see that within the pharmacy settings. Our clinics do usually have those, whether it comes from mammogram screenings or hepatitis screenings or something. So that may be something in our near future. We'll have to get with our corporate team and marketing team to see if we can promote shingles.
Yes, and I think a t-shirt goes a long way. So that's always important to remember. And again, just the efforts always should be pointed not just towards the community, but also within the staff. And it's always important to acknowledge the staff burnout. We always need to appreciate everybody within the staff to be able, they're really the ones that are driving all of these efforts. So we need to remember to apply some of these quality improvement programs towards them as well, with incentives or anything to be able to appreciate them. And I know we're coming coming towards the end of our session today. So if there's anything else that anybody has any questions about, or any other final points or anything that they would like to bring up as we close out our session. Well, I think everybody did such a great job today. Thank you so much for sharing all of your expertise with us. And just a reminder, all of our webinar sessions are recorded and they're on our YouTube page, but I think one of my colleagues posted that in the chat. So this recording will be on our YouTube page. We also, again, have all of those resources that are available for pharmacists, those in the clinic side. We also have our infographics available. So again, just resources to be able to guide those conversations and be able to promote the vaccination or shingles vaccinations within communities and health systems. So I think we have about 4 minutes left. So I don't know if we want to, we can call it a day and close out our conversation now. And I hope everybody has a great rest of their weekend. And please do not hesitate to reach out if you have any questions or anything else.
Thank you.
Thank you so much, everybody. Bye. Thank you so much.
Everyone.